Welcome to the other side of Lucy Letby. In episode 37, we're going to look at the case of BBL with cross-reference to the case of BBF, because these are the two insulin cases that were the most egregious cases against Letby, if you could even put them on a scale. There's no scientific basis, and in fact there's a lot of contrary science to what these people say Lucy Letby did. And it's very important that we look at some of the detail that is a bit technical. We'll try and keep it not technical so that people can understand why this is a shameful conviction and why I don't think it would happen in any other civilized jurisdiction. These cases aren't based on any reasoning. People must have had to sit down and kick back and forth ideas as to how they could ensnare Letby into this as a crime. Because you need to jump through so many illogical hoops, and you need to disregard so many other consequences of very high insulin levels in order just to pin this on Lucy Letby. That's my scientific opinion. If you look at this, it makes no sense whatsoever. It makes no sense physiologically, biochemically, and mathematically. It just doesn't make any sense. Somebody had to sit down and invent this. I don't know who, I don't know why, but I cannot imagine that it came up as a serious proposition, that these blood tests weren't simply erroneous, because immunoassay tests are not particularly suited to this task, and they go wrong quite frequently. Remember, both BBL and BBF survived unharmed from these catastrophic doses of insulin, something I find not only improbable, but impossible, to be honest. There is an old saying in medicine that hoofbeats in the dark are more likely a horse than a zebra. The hoops that people have to go through to create this type of story reminds me more of a circus act than actual medical practice. There are straightforward reasons why babies are hypoglycemic, low blood sugar, or hyperglycemic, high blood sugar. And both of these situations are very common in clinical practice. Most of them are relatively easy to explain and to understand. And therefore, there's no necessity to go into the Roald Dahl world of medicine in order to get straightforward explanations and understanding of what's happened. And indeed, in both of the cases, BBF and BBL, the clinical work just went on. The babies recovered from their hypoglycemia or hyperglycemia or a combination of both and settled down into euglycemia, which is the normal blood sugar ranges you would expect. And this is the sort of thing that happens all the time in preterm nurseries. It's a question of managing a problem that you know is likely going to disappear. It's also interesting that we've since found out that there was a third insulin poisoning case there. Another baby had a very high insulin level and low C-peptide level, but I'm still waiting for that person or the nurse who looked after that baby. I'm still waiting for them to be prosecuted for murder. Perhaps Cheshire Police are up to their eyes in the other 80 cases that Dowie Evans gave them. I suppose we'll have to wait until they've dealt with all of Dowie's 80 other cases. The nationwide hunt for the victims of Lucy Letby, up to 4,000 if we are to believe what we're told. And it puts me in mind, and I'm sure it puts many people in mind, of the post office scandal in the UK, where one year there's 2 or 3 thieves, the next year there's 200 or 300 thieves, a bit like the crucible, and no one works out that it's actually a systemic problem and not the result of crime. Except we all know that they did know it was a systemic problem and not the result of crime. And I suspect there are people who know that this is true also of Lizzie Letby. So we have done an analysis of BBF before, and I linked that. But we're going to look at BBF and BBL together now to find some commonality and explain what went wrong or what could have went wrong. So we'll start off with a basic recap of BBF and the circumstances around BBF's birth. Some of the agreed facts in the case of BBF are given in the evidence that the baby was born on the 29th of July. So we don't know what time it was born at, but the baby required resuscitation at birth and was later intubated, ventilated and given medication to help its lungs. And then on the 31st of July, so that's obviously the next day, a high blood sugar reading was recorded for him, and he was prescribed a tiny dose of insulin to correct it. At this time, his breathing tube was removed and he was given breathing support. And then we jump 3 days ahead to the early hours of August 4th, which is very strange. No description whatever in the public record of what happened during those 3 days, and particularly what fluids and glucose did the preterm neonate get during that time. Because we can see that there's an awful lot of pissing about with TPN bags and lines and the usual stuff in this chaotic place. So first of all, just let's have a look at Dr. Gibbs and what he says. After all, he's the consultant in this place. He's the one that is supposed to be in charge. He's the one that's supposed to be making these decisions. So we should hear what he has to say. First, Dr. Gibbs starts off with the usual painting out the Countess of Chester Hospital as being a model hospital. And he talks about he was the consultant of the week when BBE and BBF were born. And the clinical responsibility meant he would go around the neonatal unit for a full examination. So just one full examination, great. In addition to going around the unit every other day for observations, every other day, but not a full examination. Good, that's how we run a model neonatal intensive care unit for babies that are this size and this vulnerable. We have a consultant over a week, and we do a ward round every second day, and we get one full examination, and we have a ward round for observations every other day. But there's not a lot of decision-making going on here, from what I can see. He said that was standard practice for consultants in hospitals across the nation, as had been the case for many years. I don't know if I'd agree with that. There'd be a lot of good hospitals where these babies would see a senior physician every day. He adds the number of neonatal unit deaths up to 2015 were within the normal range or lower than the average, up to 2015 and 2016. Now, we've talked about this before and the work of Scott McLaughlin and Norman Fenton, that there was a surge in deaths, a spike in deaths in many neonatal hospitals in 2015, 2016. Don't know why. And some of them are even higher than this. But I suspect that the Countess of Chester Hospital wasn't taking babies of this complexity up until 2015, 2016. But something went on either at the Countess of Chester Hospital or within the network that change in that policy or those circumstances. He said the practice has been changed in 2016 in many hospitals for there to be a consultant of the week in the neonatal unit and a separate consultant of the week in the paediatric ward. So it's just all, we've thought all of this through and there shouldn't be any worries, but that's not really the case. He said for the Countess of Chester Hospital, it had followed the higher than expected mortality rates in the neonatal unit 2015-2016. Dr. Gibbs says the blood glucose level for baby F, as noted by a colleague, of course as not noted by him, soon after birth was satisfactory at 2.7, as it should ideally be above 2.6. He said the following reading was 1.9, and that can be a natural consequence of the separation of baby from mother. So it was not unusual in itself, and was more commonly seen in premature babies, he told the court. But what he didn't tell the court is that that state of the inability to maintain a blood glucose level can go on for weeks, because this little baby has depended 100% on the mother to regulate its blood sugar, which she did in utero. And now it's suddenly been torn from that environment. It has to do it itself. But all of the hormones that work together in harmony in a very complex way to produce insulin, move it around the place, get it to act, get it to do all the jobs it has to do, balance it up with all the other hormones that counteract insulin and all that stuff, that's not going to just turn on overnight. That's going to take time to turn on. And most people will agree that it probably doesn't begin to stabilise really until around about 34 weeks. And these babies are a long way from that. So what we can expect from this baby is either episodes of hyperglycemia, high blood sugar, hypoglycemia, low blood sugar, or both, or periods of normality in between, followed by either hyper or hypoglycemia. It can go on for quite a long time. He goes on, the baby F was struggling with his breathing, so he started an infusion with glucose. So he's immediately connecting the struggling with breathing with the glucose. It's just all calculated. The baby was struggling with his breathing because he had respiratory distress syndrome. The glucose is not going to have any direct effect on that, but he wants to link in the mind glucose with struggling to breathe. That's all he's doing here. The blood gas reading for BBF is shown on July 30-31. BBF had been born on July 29th. The glucose reading at 10 p.m. is 15.1, an abnormally high amount. Dr. Gibbs said the reading shouldn't go above 7. Some people say 8, some people say 9. He said that could be indicative of infection, and BBF was put on antibiotics. Well, it could also be indicative of you gave the baby too much glucose, and that's the iatrogenic reason, or the doctor-caused reason. That's the most common reason that it happens. You have to pick a standardized dose of glucose or dextrose, get it started, and see what happens. Sometimes you overshoot it, which is why you have to keep checking it. So a single blood sugar level reading would be monitored, and repeat high readings would lead to action taken, Dr. Gibbs tells the court. Because the blood sugar level reading on July 31st at 12:22 a.m., this would be 2.5 hours later, which is just about acceptable, was 13.9. Child F was administered with insulin in a very small dose, carefully controlled. And the very small dose, carefully controlled, was 0.01 units per kilogram per hour to 0.05 units per kilogram per hour. A tiny dose indeed. Now we're about to hear Dr. Gibbs tell us that that minuscule dose of insulin is about to have an effect. And by saying that, he's setting the benchmark for the insulin sensitivity in this baby. That means how well we can expect BBF to react to insulin. Dr. Gibbs says the administration of insulin at 3:40 a.m. meant the junior doctors had waited until a couple of high blood glucose readings had been recorded. At 4:41, the blood glucose level was 8.7, which Dr. Gibbs says meant child F was responding well to the insulin infusion. So Dr. Gibbs is saying that the sensitivity of this baby to insulin was good enough to start dropping blood sugar from 13.9 to 8.7 without any bother at all. The baby was sensitive to the insulin. Dr. Gibbs says the insulin infusion progress is fairly predictable. So here we have Dr. Gibbs making stuff up again. There's no way that anything you do with a preterm neonate is fairly predictable. I mean, the initial dose, yes, you agree on that. Then the dose increments titrated up. But there's a huge variability in response. There are even sex differences in response. And there's a risk of hypoglycemia. In one study, 25 out of 43 infants in the tight glycemic control group experienced hypoglycemia. That's how predictable it is. But we're not talking about these tiny doses of insulin in the accusation against Letby. We're talking about mountains of insulin by comparison. And they are certainly going to be more predictable in what they do. You're going to poison someone with hundreds of times the normal dose of insulin that you would give a baby. Dr. Gibbs is arguing with himself. He says the effects of insulin are predictable. If he truly believes that, then he cannot believe that this is an accurate measurement of insulin in baby F and baby L. He carries on. He said it remained lower, so the insulin infusion was stopped at 6:20 a.m. So it took 3 hours of 0.01 unit per kilogram per hour to correct that blood sugar, to drop it from 13.9 to normal. Then he admits that BBF was recovering from respiratory distress syndrome. I'd be a long way from recovering from it at 3 or 4 days of age. And he was being treated for sepsis. And he had lost weight from birth. He'd actually lost 10% of his body weight. And he was dehydrated by their own admission. So they couldn't manage the fluids in this baby. And it seems to be that they can't manage fluids in any baby. All of these things, these little details, are what the neonatal specialists spend all their time doing. The blood sugar levels were still moderately high, between 5 and 10. He had some jaundice, which is common in premature babies, and a note for a heart murmur is made, but Dr. Gibbs said he had not heard upon examination of baby F. But we do note that the baby had some jaundice, and he doesn't tell us how much jaundice. But someone needs to look and see how much jaundice, because jaundice will certainly interfere with an immunoassay test. And that information wasn't put on the request form, which said hypoglycemia only. That was all the clinical information that Milan had. BBF was on standardised TPN fluid nutrition, plus nasal gastric feeds with express breast milk. We don't know how many calories are coming from the breastfeeding, and we don't know what the glucose infusion rate was for the baby. So we don't know what the total energy input was. Dr. Gibbs says standard TPN bags would continue to be administered with newborn babies, with any tailored additives for babies depending on their requirements. This is the bespoke bags they talk about. And that would be administered via a separate infusion method. You're putting the dextrose into one branch of the central line, and you're putting the TPN into another branch of the central line. And that gives you the flexibility to adjust both separately. Dr. Gibbs said he couldn't hear a heart murmur because the CPAP machine was on. Like, it was too noisy for him to hear, so he just wanders off. I don't know. So that may explain why he couldn't have heard any heart murmur, or there may not have been a heart murmur. But wouldn't you really want to know, is there a heart murmur? Because the heart murmur, the characteristics and the location, they could point out clinically that you had a problem with the heart. But no, it mightn't have been there, it might have been there, I couldn't hear it. Dr. Gibbs says BBF, the plan was to increase BBF's nasogastric milk as tolerated. And this is another thing about this unit. I have a very high suspicion that they were really pushing these gastric feeds on these babies to the point where they were not tolerated. You have to build that up. That can take days and days to build up, but they were building it up too quickly, so I don't think they could manage the feeds. And this was part of the reason why these babies kept getting all these symptoms of feeding intolerance. Bloated stomachs, vomiting, projectile vomiting, because they're overfeeding them beyond their capability of digesting the food. He goes on pretty much to confirm that. He says he was told about multiple small milky vomits and feeding intolerance. We see this over and over again in this unit. So much feeding intolerance, bloated stomachs, vomiting, projectile vomiting, because they're overfeeding them beyond their capability of taking the food. He goes on pretty much to confirm that. He says he was told about multiple small milky vomits and a 9 ml milky aspirate and a heart rate above 200 beats per minute, which he says was high even for a premature baby. But otherwise, he says, baby have presented as a healthy baby. So the baby has no symptoms of hypoglycemia, none whatsoever. The baby is a healthy baby. That's what he's saying. The sudden increase of heart rate over 200 was very unusual. Yeah, everything's very unusual in this place. It's what happens in hospitals all the time. They're not very unusual. They're just problems you have to deal with. Dr. Harkness had assumed the change in observation was down to infection. Could have been. And Dr. Gibbs agreed. But Dr. Gibbs said it was a very rapid change, even for an infection. And there would normally be signs of child life deteriorating beforehand. No, there wasn't, not necessarily. The plan was to re-screen for infection and start a new line for different second-stage antibiotics. The August 5th intensive care chart for BBF is shown to the court. Dr. Gibbs says the nasogastric feed tube was stopped, nil by mouth, so there's no more of this, whatever mils, 10, 15 mils, whatever mils they were given of the feed, that's now stopped. No more glucose going in that way. That meant the TPN bag had to be changed to account for the administration of new medication via a long line. On August 3rd and 4th, the blood sugar reading for BBF is 0.8, abnormally low at 154. Now we know, and we've said it repeatedly and we'll say it again, you cannot rely on these very low blood sugar readings when you're doing them at the bedside. They're not designed to measure blood glucose in that range. They're designed to measure blood glucose in the normal range. So you have to discard that result and say, we need to do a laboratory test. The August 3rd to 4th readings shown were between 3.8 and 5.4, which Dr. Gibbs says were normal. Dr. Gibbs says 0.8 is a worryingly low trend for the baby. It's also a worryingly low, inaccurate reading for the baby. A bolus of glucose was administered, with Dr. Harkness giving an additional administration of glucose and sodium chloride to keep the blood sugar level up. The following blood sugar reading was 2.3 at 2:55 a.m. Much improved, but still low. So the plan would have been to continue to monitor the readings carefully. The additional provision was administered at 4 a.m. This is the extra glucose and the sodium chloride. Dr. Gibbs said Dr. Hartness likely had concerns over the heart rate rising suddenly, wondering if BBF had an inherent problem with the heart rate, a thing called supraventricular tachycardia. So SVT, supra just means above, ventricular just means the ventricle of the heart, the pump, main pump, and tachycardia just means fast. However, those readings would see a heart rate of over 200. So were recorded as unlikely. No, they wouldn't necessarily go to over 300. They could be 200 and still be SVT. But they could also be dehydration. They could be the result of electrolyte problems, particularly potassium. Or it could have been linked to a heart murmur, which no one has bothered to clarify by an ultrasound whether there's a problem there or not. But no, it's going to be due to Lucy Letby because everything in this hospital is due to Lucy Letby. So he admits that dehydration was also a possible cause. Why would you allow your baby to become dehydrated? But that's just a throwaway comment to him. Fluids and saline were administered to treat the possible causes. Dr. Gibbs said that BBF had an extremely high level of insulin in the body later that day, as revealed by a subsequent test result. Now, he had a level around 4,600 picomoles per litre. Now remember, Dr. Gibbs has kindly provided us with the sensitivity of the baby. So let's just do a little back of the envelope calculation regarding the amount of insulin that the baby has already received therapeutically. So remember, the starting dose was 0.01 units per kilogram per hour. The baby weighs 1.3 kilos, roughly. And the conversion factor is 1 unit is 6 picomoles. So if we take that and we calculate units per hour for this patient, 0.01 by 1.3, it's 0.013 units per hour. And we convert that to picomoles, we get 0.078 picomoles per hour, which Dr. Gibbs said BBF was very sensitive to, and it was sufficient to lower the high blood sugar. These people are now going to claim that in BBF the reading was 4,600 picomoles per litre. So why don't we convert that back to units per litre? It's about 760 international units per litre. ACRapid, as we've been told, is supplied to the pharmacy in the 10 ml vial that was shown to the jury dramatically, and that contains 1,000 international units. So we would have to say it was 3/4 of a vial. But it's even worse than that, because 50-60% of this insulin will be absorbed by the TPN bag. Darry Evans has told us you never put it in the TPN bag for that very reason. So now we're up to 1.5 vials. But let's not forget, Letby spiked 2 bags. So we're at least 3 vials now, which didn't, as I recall, show up in any audit of the insulin in this ward. Now, this is just one way of looking at it. There really is so much variability, complications, interactions, all kinds of things that perhaps this flippant calculation ignores. But I don't think it's any less flippant than the calculations that they used to come up with their tiny amount of insulin that Letby used. So 3/4 of a bottle. But yet, it's having minimal effect on the baby, whose insulin sensitivity we have already established by the use of minute doses of insulin. But it's worse, because we have to sustain this over a 17-hour period. But Dr. Gibbs carries on. He notes from 8:30 a.m. on August 5th, recorded a natural increase in heart rate due to BBF stress. The blood glucose reading was 1.7 despite administration of glucose, and I would say despite an inadequate administration of glucose. He also had signs of decreased circulation, a sign that he was stressed, dehydrated, or had an infection. While the blood glucose levels had risen to the 2 during the night, the latest 1.7 was unusual and unexpected, as baby F had had glucose administered, but did not seem to be responding. But these are bedside readings. They are measured at the lower limit, and they're not valid. Dr. Gibbs goes on, at the time we didn't know this was because he had had a large dose of insulin inside him. He didn't have a large dose of insulin inside him. He had 4,700 picomoles per litre of insulin inside him. But all we have as a consequence of that is he's a bit stressed, dehydrated, has an infection. At 11 a.m, the TPN, which includes 10% dextrose, was off as the line had tissued, and it was restarted at noon. That TPN was stopped at 7 p.m. and replaced with a 15% dextrose infusion, Dr. Gibbs tells the court. So now we have 3 different insulin preparations. The one that was running, but we don't know for how long. It had tissue in the baby's leg, had swollen markedly. So was any of that dextrose actually getting into the baby at all? Probably not. That's why the baby's not responding to the dextrose. Then it stopped at noon, and the TPM was replaced at 7 p.m. with a 15% dextrose infusion. So that's 3 different bags. Dr. Gibbs says the blood sugar levels remained low, sometimes worryingly low throughout the day, 4,650 picomoles per litre, but it's only sometimes worryingly low. The reading was 1.9 for much of the afternoon, despite 3 10% dextrose doses being administered during the day. He adds, after 7 p.m, the blood sugar readings at last go to the normal reading of 4.1 by 9 p.m. Dr. Gibbs says dextrose administrations had some minor effects at times, other times no effect. But when they whack it up to 15%, which is what the baby obviously needs, the glucose infusion rate is now adequate and the glucose starts to rise. But no, there must have been 4,600 picomoles per litre of insulin available in one or all of the bags that Lucy Letby poisoned. The simple explanation for this is that the glucose infiltration rate wasn't adequate enough, and that's very common. You have to build it up. You switch it to 15% and it works. The blood sugar reading at 6 o'clock on August the 5th was abnormally low at 1.3. And that's when the test was sent to the Liverpool lab. So after all of that, they send an insulin immunoassay test to the Liverpool lab. And we're going to look now in a second at Dr. Gail Beach's records to see if we can get even more insight into this mystery. Dr. Gibbs goes on to say that there should be virtually no insulin measured in the blood of this baby. But that's more storytelling bollocks, because preterm neonates can have high insulin readings and have low blood glucose. And it's a phenomenon known as hyperinsulinemic hypoglycemia. And it occurs in these preterm infants because of insulin resistance or impaired insulin production. They can have inappropriately high insulin levels relative to their blood glucose concentrations. Because of hyperinsulinemic hypoglycemia in preterm neonates, you get a delayed adaptation of the pancreatic B cells from the fetal state. So this is all part of this transition from the womb. And you get impaired suppression of insulin secretion at low glucose levels. Perinatal stress, illness, all of these can explain hypoglycemic hyperinsulinism. These people are taking adult physiology and applying it to preterm neonate that is in transition. And it's a fraud. Dr. Gibbs goes on to say the ratio of C-peptide insulin is marked as 0 when it should be 5 to 10. Dr. Gibbs says the insulin C-peptide reading should be 20,000 to 40,000 to correlate with the insulin reading in this test. The doctor says the insulin results showed BBF had been given a pharmaceutical form of insulin administered, and he should have never received it. All so simple, but yet it had practically zero effect on the baby. How can that be? An unnamed nurse who had looked after BBF during the night of this catastrophic level of insulin said that she was very happy with the baby. But funny enough, the line tissued, as they call it, shortly after that comment. And we don't know how much glucose was going into this baby. Most of it was going into the tissues around the leg. It wasn't getting into the bloodstream at all. And that's why the blood sugar was low. Let's look at what Dr. Gail Beats said. Dr. Beats said that she was present at the birth of baby E and baby F and looked after the former. So she looked after baby E. Her first involvement with baby F was during the day shift on August the 4th. That's the day of the incident. She said it would have been usual practice that she would have been told about the death of baby E as part of her handover for that day shift. A ward round is presented to the court, filled in preparation for weekly consultant grand rounds. The list of problems, readings and observations for each child are noted. Dr. Beach explains child F was born premature. We don't know how premature, but premature. And the note recorded baby E had died aged 6 days. Baby F was on Optiflow. So here we go again. We're on Optiflow. Are these people really competent to use Optiflow? I don't think so. CPAP is a much safer, more reliable option for amateurs like this. But he had suspected sepsis and a raised urea and creatinine. Creatinine is a breakdown product from muscle and protein metabolism, and it's released at a very constant rate throughout the body, depending on muscle mass. It's usually elevated in preterm neonates anyway, and it's secreted through the kidneys. Urea is an organic compound, and it's made in the liver and part of the urea cycle. It's another way of getting rid of amino acids or reusing amino acids or from ammonia, and it's excreted in the kidneys. And it sometimes is elevated too in preterm neonates, but it's called blood urea nitrogen, and it shouldn't really be elevated. The urea you don't want to be elevated the creatinine, you're not really that much bothered about it. But it shows that the kidney function is either impaired through illness or immaturity. And dehydration, metabolic stress, medications, all of these things are affecting the kidneys in this baby. But I suspect because the weight loss is so great in this baby, 10% within the first few days is not normal, that the baby was probably profoundly dehydrated. And then they are pumping the baby with these hypertonic solutions. And what the hypertonic solutions are going to do, as the baby uses up the glucose, it's essentially the same as injecting the baby with water itself. But water itself will not correct dehydration. You need to have salt with it. So that's going to balance the osmotic pressure, that's the push-pull pressure on either side of the cell membranes. So they're compounding the dehydration by giving hypertonic solutions. They're probably getting a diuresis. In other words, they're getting urine coming out. And they're being fooled by the fact that the baby's actually dehydrated. But it looks like it's okay because it has to get rid of all this excess water. Otherwise, it's going to mess up all the other electrolytes in the system. And Dr. Beach carries on. And she says that the baby's weight had dropped to 1.296 from 1.434. That is a huge drop. That's 10%. But she said that wasn't a concern. And she confirms that baby F was receiving nutrition via TPN, but he was active and moving all four limbs. But I keep saying he wasn't moving anything. The limbs move because of reflexes. The baby is not initiating moves. Baby F was active and pink with a clear chest, no increased work of breathing. The baby was fine, despite the fact that it's got 4,600 picomoles per litre of insulin in it. And then she's asked to look at a chart for a prescription of Babivin. And Babivin is just a commercially produced, pre-made total parenteral nutrition that has 10% dextrose and then a little bit of amino acid and some electrolytes in it. And she said it's a standard bag. But she also says something weird. She said that it would be given at a bespoke rate for baby F. But there's no such thing as a bespoke rate for dextrose. You have to give as much as you need. Dr. Bates says the second prescription with different Babivin levels and a new lipid level was made for baby F because he was now nil by mouth. So we're all over the show here, changing bags to different bags, first bag, second bag. It's pretty much impossible, in my opinion, to know how much glucose, how much water, how much electrolytes are gone into this baby at all. And then she makes a really weird note. At 5:40 p.m. on August 5th, to prescribe 150 mils per kilogram per day of 15% dextrose over 24 hours at a handover, with 5 mils per kilogram a day in it. 5 mils per kilogram a day of what in it? I have no idea what this means. Also, to stop TPN, check the urinary sodium, cortisol, and insulin. So we hear no more mention of that. But why would you check insulin in the urine without checking C-peptide in the urine and without checking glucose in the urine? Glucose in the urine can be measured by a dipstick. Dr. Beach says she cannot remember a BBF had been prescribed additional dextrose doses, but she's got the notes in front of her. She says the 15% dextrose is a high amount and would normally be due to low blood sugar levels. 15% dextrose is what it is. 15% dextrose It's not a high amount. Sometimes they need 10%, sometimes they need 5%, sometimes they need 15%. An intensive care chart is showing 5 a.m. 2.5, 2.9 reading. That's fine. Then 1.8 and 1.9. So how much glucose was the baby getting? How much impact was the tissuing of the line having on the baby? We don't know. We have no idea. And the blood glucose level was sent to the lab at 6 o'clock because that gives you a more accurate reading, because that tends to be more accurate. No, it's not tends to be more accurate. It is more accurate, particularly at low levels. Cortisol reading is 364, which is within range. And the insulin reading is 4,657. The insulin C-peptide reading is less than 169. Dr. Beach says the insulin reading is very high. While there is no normal upper limit, that reading would be considered high. There are acceptable upper limits, but they wouldn't come anywhere near this astronomical level. And she says that the insulin C-peptide reading is the lowest reading the machine can record. But remember, in the last episode, we talked about the baby that actually did have an actual rapid overdose. It had no C-peptide, zero C-peptide. There's a little bit of something going wrong here, and we'll look at the spec sheet of the test that was used to determine these things. And she interestingly says then that a urine sample sent at 7 o'clock or 6:45 had no unusual readings. But Dr. Beach tells the court she cannot think off the top of her head how to interpret those results recorded. And I don't blame her. I certainly don't blame her. And now we jump to Dr. Anna Milan, who doesn't say a lot in this case, but she is a clinical biochemist, and she explains how insulin and C-peptide tests were taken for analysis. And the blood sample is dated August 5th, and it was taken at 5:56 p.m. The court is showing a screenshot for baby F's blood sample result, and Dr. Milan says baby F's insulin C-peptide reading of less than 169 means it was not accurately detectable by the system, right? The machine was inadequate to produce the result she needed. That's what that means. The insulin reading is recorded at 4657, and a call log information is made noting a logged telephone call made by the biochemist to the Countess of Chester Hospital with a comment, low C-peptide to insulin. The comment does not say no C-peptide to insulin, low C-peptide to insulin. And then it says, exogenous. That is a query whether it was insulin administered. And the reason that she has to put that in is because she wasn't told any of this on the form that was sent to her. She wasn't told about the jaundice. She wasn't told about the abnormal kidney function tests. She wasn't told about the dehydration and the weight loss. It just simply said hypoglycemia. That's all it said. It didn't say anything else. So she had inadequate information in this chain of custody before she did the test. And then she suggests that send the sample to Guildford for exogenous insulin, which to me is an admission that she cannot rely on the reading that she's just taken. The court hears Guildford has a specialist separate laboratory for such analysis in insulin, although the advice given to send the sample is not usually taken up by hospitals because it's not usually needed. But we find out in the Thirlwell inquiry that the proper mass chromatography machine is actually in Germany. So that's how infrequently you do these types of tests. And then she said that she was very confident in the accuracy of the blood test analysis produced by a BBF sample. But she also said in the same evidence that it wasn't accurately detectable. So how can you be confident in a machine that cannot accurately detect? And Myers goes on, and he asks about the risk of a sample deteriorating if it's not frozen. And Dr. Milan said the sample arrived frozen. If it wasn't frozen, it would be accepted in 12 to 24 hours. She said the laboratory knew it arrived within 24 hours, and as Chester has its own system in place to store the blood sample before transport. Mr. Myers said BBF's blood sample would have been stored for 7 days in Liverpool, then disposed of, and Dr. Milan agrees. On a query from the judge, Mr. Justice James Goss, Dr. Milan explains how the blood sample is frozen and kept frozen for transport. She said the sample would not have been taken out of the freezer in Chester until it was ready to be transported. I'll tell you about forensic testing. I did many blood alcohol tests on people in custody. There are 2 boxes. You have to split the sample. You have to label it. You have to get the patient to sign each bottle. Then you offer the patient one of the bottles so that they can have it independently tested. And that has to be witnessed by a police officer before it can go in to custody. And I had an unfortunate incident that was nothing to do with me. A drink driver had unfortunately killed 2 people. And I was asked by the Irish police to go and take a blood sample from this man in accident and emergency because he was injured too. We got his consent. We recorded his consent. We logged his consent. We went through the whole process of forensic chain of evidence. And unfortunately for us, because he was in a hospital environment, and despite the fact that I washed his arm 3 or 4 times, when the sample came back, it was contaminated by 1 part in a million of isopropyl alcohol. And the isopropyl alcohol is the alcohol that's in the hospital swabs. So the people who had originally treated this guy had obviously used these sterile wipes. And in spite of all my efforts to clean the arm, 1 part in a million was isopropyl alcohol, and that test was thrown out. It could not be used in a court of law. But that obviously doesn't apply to the United Kingdom. I have said before, I have no doubt that Lucy Letby would never have faced prosecution in the Republic of Ireland. Her defence would never have been so lousy, and these consultants would not have been softballed at all. They would have been torn to shreds in court. But why does Miss Milan suggest that the blood is sent to Guildford, the proper lab? It's an admission that her lab is not adequate and her testing method, the Roche-Alexis system, is not adequate to prove exogenous insulin administration, and the levels are simply too high. Given the clinical picture, these blood sugar levels were hovering around low to normal because they were most of them being measured by bedside readings, which are not accurate. The baby was not unwell. The baby did not go into seizures and comas and all the other things that you would expect, but such a massive amount of insulin in the body. Remember, in the other case, I told you the baby ended up on a ventilator for 2 weeks. It was so ill. And its blood insulin level was lower, 4 times lower than this This simply doesn't make any sense whatsoever. We also have to consider what's called the glucose oxidative capacity, and that's the maximum rate at which glucose can be oxidized or metabolized to produce energy. And for preterm neonates, the maximum rate accepted by most people is 6 to 8 milligrams per kilogram per minute. That's the most that a baby can oxidize to produce energy. It's a bit higher for term babies, but it's 6 to 8 milligrams per kilogram per minute. So if you give more than 6 to 8 milligrams per kilogram per minute, what would happen? This is regardless of the level of insulin, because what goes in must come out. So this is the upper limit of the glucose that can effectively be used to make energy. And if you exceed that capacity, you're obviously going to create complications. And the first of those complications will be hyperglycemia. So we don't have hyperglycemia, we have hypoglycemia. So we're not giving too much dextrose. And if we were, we would also then exceed the oxidative capacity, and the glucose would have to go somewhere else. And where it would go would be it converted into fat. And if we convert it into fat, we will increase carbon dioxide production. But that's not mentioned. The baby's breathing on this OptiFlow in air, no increased carbon dioxide. And in order to do that, you will need higher oxygen consumption. The baby didn't need higher oxygen consumption, and it will appear or begin to appear in the urine as glycosuria, because the kidneys, number one, are impaired because the blood urea nitrogen is elevated, and they're immature and they're very sensitive to glucose. So in preterm babies, you would get glycosuria if you were putting too much glucose into the baby. There was no glycosuria, therefore there was no excess glucose. They gave enough to keep the baby going and restore the baby's glycogen stores to enable it to get into a euglycemic state. That would have been impossible to do with 4,600 picomoles per litre of insulin floating around that baby for 17 hours. But none of this information was available to Dr. Milan. None of this information is taken into consideration. The test used was the Roche Alexis System immunoassay test. And what Roche say about the Alexis insulin test is that it is designed, test purpose, designed for the in vitro quantitative determination of human insulin in human serum and plasma. And its intended use is the diagnosis and therapy of various disorders of carbohydrate metabolism, including diabetes mellitus and hypoglycemia. The test is designed to detect human insulin. On the spreadsheet for the Roche test, you will not find a single mention of the word exogenous insulin or ActRapid. So while it may detect ActRapid, which is a form of human insulin, the test is not specifically designed or optimized for this purpose. And so that means that its ability to accurately quantify exogenous insulin preparations such as ActRapid would depend on factors such as specific epitopes. And an epitope is just basically a portion of the antigen that binds to a specific antigen receptor on the surface of a B cell or to an antibody. So epitopes stimulate immune responses by binding to specific receptors, and that's why these tests are designed to pick up specific sequences of amino acids that form insulin. But a typical epitope is 5 or 6 amino acids long. That's it. You are down to such a small level, microscopic level, that there are so many things that can overlap these amino acids. And it's impossible when you're testing these amino acids to test for every possible epitope that it may interact with. It's simply not good enough as a forensic test to put someone behind jail for the rest of their life. So there we have it. This doesn't make sense clinically, doesn't make sense biochemically, doesn't make sense physiologically. And we will finish this off in episode 38, where we look at what Professor Marsh had to say and see if we agree with his expert evidence. So I'm not buying this one. It needs to be revisited urgently. And I'll see you in the next episode. Bye.